That's okay. We're back on. So let's start with your first question.
Okay, my doctor said that cryoablation is only for older people and smaller tumors. Is this true?
Well, eventually we're all older people, so I guess it's eventually something that each of us is a candidate for, but it is traditionally a treatment that's been considered for small, non-aggressive tumors. And since there's some correlation between, smaller tumors being detected in women getting screening, older women, and since it's a solution for smaller tumors, then it's something that is generally more likely to be accepted amongst an older patient population. There's also a little bit of mythology thinking that, it's because it's not a treatment that gives the same confidence as, say, surgery, that you're willing to take a chance in an older woman who might have less, chances of survival. I think that's kind of the wrong thinking. What's important about cryoablation is that it's a treatment that is designed to treat tumors, kill them completely, and to treat them with a margin. And the way that cryoablation is delivered, and I have a few props to show you, is that we are able to ablate with each breast cryoablation procedure an area that's about this large. So what we're limited with, therefore, is the treatment of tumors that can fit into this space, which is why small tumors is generally the idea. So just by comparison, if you imagine a penny, which is 19 millimeters, you can fit the penny into the oval ablation zone. And so that's a small tumor that works well for cryoablation. Or if you have something the size of a nickel, which is 21 millimeters, it too can fit into the size of the ablation zone. What that traditional thinking doesn't take into consideration is that sometimes, based upon the patient and the problem, we can actually combine multiple ablation zones so that we can treat a larger area and perhaps treat something the size of a quarter, or maybe with 3 cryoablation zones, something the size of a $50. So thinking of it as simply a problem for small tumors is true if you only think of a single ablation. But as we know from cryoablation of other organs, where we often cryoablate larger things, when you combine multiple ablations, you can actually treat a larger tumor. That's the first answer. The second thing is that it's not really an issue of age or biology. Cryoablation works well against all tumors. It's just a matter of the anatomy. Can we get the tumor within the cryoablation zone? If it's a young woman or an older woman, it would be expected to work equally well.
What can we expect after cryoablation? For example, does it change the shape of the breast? Will the breast be hard and swollen? If so, is it only temporary? And how long does it take before the lump is dissolved? And how long do we have to wait before we can go back to doing normal things like saunas and exercise?
Thank you. Well, we'll go back to my my oval circle. What we're doing with cryoablation is that we're ablating an area that's about 3 by 4 by 3 centimeters. So 4 centimeters in this direction, 3 centimeters in that direction, 3 centimeters in that direction. And so, that is the injury, the area of dead tissue that's left behind. It takes about 3 to 4 years or 2 to 3 years to go away, depending upon the nature of the breast, how close it is to the skin. So one should expect to feel a lump that lasts for a number of years, but it becomes progressively smaller over that time period. So even if it didn't have a lump that they could feel at the beginning, maybe the tumor was too small to feel, following cryoablation, they'll have a lump that is the necrosed or killed tissue that would take a few years to go away.
That was me. I couldn't feel mine before, but I could feel it after.
Exactly. And then as well, after the treatment, there's some swelling that occurs. With any injury, there's swelling. And so in the first few weeks to months, you feel additional swelling around the area that might be the size of a lemon, say, for example. But once the initial injury goes away and you're just left with the killed tissue, which is again smaller, it will take that 2 to 3, maybe 4 year period to just gradually dissolve. Now, your activity level, however, is much more liberal than if you compare it to surgery. This is performed through a 3 millimeter incision, so it's just a small skin injury. So I generally tell patients to maintain light physical activity the first 2 weeks, so nothing that requires pushing, forceful use of the upper body, and to wear a sports bra or snug fitting bra to help reduce the swelling, reduce the bruising, and to encourage the swelling to go away. Once they're through that period, which lasts about 2 weeks, there should be no restrictions. They can do everything that they were doing before without restriction.
Do potential cryoablation patients need both an ultrasound and an MRI scan to send in to see if they're a candidate?
That's an important question, and it frequently comes up. The issue has to do with the anatomy of the problem. The accuracy and the effectiveness of cryoablation depends solely on how well we see the target and how well we can ablate it, how widely we can ablate it. Routinely, patients have mammograms, so mammograms provides information. Ultrasound is important because cryoablation is generally performed under ultrasound guidance. So we would introduce the ultrasound as we're looking at the tumor, introduce the cryoprobe as we're looking at the tumor and pass the cryoprobe through the tumor. And that's an important imaging study because it's the study that guides the procedure. However, we also know that sometimes there are parts of the tumor that can be detected on MRI that are not apparent on mammography or ultrasound. The tumor might look like it's 2 centimeters by ultrasound, but might be 3 centimeters by MRI. Or in a case I did this past week, she had 2 adjacent tumors that showed up on mammogram and ultrasound. But then we did the MRI and we found a 3rd one nearby. And had we not performed the MRI and detected this 3rd area, we might have treated the 1st and 2nd quite effectively, but there would have been a recurrence at the edge because there was detectable disease that we would have missed. Now, no study is perfect. MRI can miss things as well because at the very beginnings of cancer development is just undetectable. But what we're trying to do is at least address what's detectable. And we know that MRI has value. In dense breast, it has more value because masses can often hide on mammography. So we rely upon ultrasound and MRI more when the breasts are dense. Sometimes patients have DCIS, which is intraductal cancer or cancer in the milk duct. That's like roots that extend out from the main tumor. Might not show up on a mammogram, might not show up on the ultrasound, but the MRI might show that there's an extension in one direction. And so it doesn't mean that cryoablation isn't possible, but it means that we have to adapt the treatment to cover the areas that we can detect as abnormal.
So is the best thing they can do is send you what they have and then you'll tell them if they need more films?
That's the starting point. And I will often recommend, especially if there's any, if the breast is what we call fatty, meaning that there's not much density and there's a fairly discrete mass, then there's pretty high confidence that the mammogram will show what the findings are and the ultrasound will be, definitive. But if the breast is dense, if there are multiple tumors already, or if they have something that makes the edges look a little less clear, then MRI becomes more important. So if they've not performed it, I'll recommend it in those cases. And a very important stipulation is that it has to be contrast enhanced. I know that's often an issue. And again, none of this is ideal, but if the goal is to make sure you understand the problem as best as possible so that you can treat it most effectively, then there's no substitute for the gadolinium that's used for MRI. There is another product called Pronovo, which is used. It's kind of a whole body MRI, which includes the breast. I've seen some studies of it. It just doesn't have enough resolution for the breasts for me to feel confident that it's excluding things that are important and telling me clearly what I should see.
What's the largest tumor that you've successfully done, and is there a maximum size you'll actually do?
There is a maximum size I'll actually do, although I'm not quite sure I've encountered it yet because I keep being pushed. I mean, before I would only treat tumors the size of a nickel, and now I'm treating tumors much larger than that. So I think partly it's, having a problem that is defined enough to target. So that, when I generally was limiting the treatments to tumors in the 2 to 3 centimeter range, I encountered someone who had a problem in the 5 to 6 centimeter range. And because it was discrete enough, and I felt that I could organize enough ablations around it to cover it widely, I was able to do it, and we did that successfully. And so because of that, I've pushed the limit of what would generally be considered to be acceptable for breast cryoablation. But not all tumors are still manageable in that way. Some are multifocal, meaning there's the tumors here, tumors there, and it might be too many places, or it might involve the skin, and we try to avoid ablating the skin because the skin will heal poorly if the skin is ablated, and so you end up getting an open wound, for example. So we try to avoid the skin, or if it's something that has a high degree of lymph node involvement as well, that's a problem that can't be really managed. I think you have a question about that later. So the main thing is to have ideally a tumor that's in the 2 centimeter size range or less. We can go larger if it's fairly well defined and it doesn't involve the skin. And there are situations as well where we have tumors that are, not ultrasound visible, but that we could ablate because we can place markers, ultrasound visible markers within it, and use the markers as a surrogate for the tumor and aim for the marker to ablate it. The largest area I've treated so far is a tumor that I think was 11 centimeters.
Oh, wow.
Yes. The patient was not willing to have conventional treatment, so it was certainly not my first, second, or third choice for this problem, but it was better than allowing a tumor to grow and progress to invasive cancer. In that case, it wasn't invasive cancer, but it would have become invasive cancer, and then it would have been a game changer for the patient. So it was a bit of a negotiation and compromise. And certainly when we get up to tumors that are that big, where the risk of recurrence is a lot higher, then the compromise is often, okay, well, I can cryoablate it, but it's necessary if we have radiation, because there are likely things I'm missing. I'm going to aim for what I can see, but there are likely things that I'm missing. And if you don't want to deal with this again, this is one way to avoid that. So sometimes we have to kind of compromise by treating a larger tumor with cryoablation, but only with the stipulation that radiation be used to make up for what cryoablation can't address.
So it's back to the whole thing of they need to send you the records and then you can tell them if they can do it or not.
Yes, yes.
Okay, when you recommend radiation after cryoablation, so cryoablation, is brachytherapy radiation an option?
So brachytherapy is targeted radiation, usually given within the cavity or within into the interior of the breast. And so the concept of cryoablation is that we're treating, with a needle, freezing the tumor with the removed normal tissue around it. But there's no actual cavity being created. So the traditional ways of giving brachytherapy don't really match well with cryoablation because there's no catheter inserted. Now, there are ways of getting partial breast radiation. So it is technically possible to give target radiation to the breast after cryoablation, but it's externally targeted radiation. So it's like the traditional radiation, is just that it's given over a shorter period of time, over fewer number of days, targeted to only one part of the breast. But the types of brachytherapies like intraoperative radiotherapy, where you can give it in a single dose, that requires a cavity. So you have to go and a lumpectomy. Or if you've had or familiar with something like a mammocyte or those types of balloon catheter brachytherapies where they place a cavity, place a balloon, and then a radiation source inside the cavity to create the walls. Again, that requires a lumpectomy or cavity.
What are the considerations for cryo with DCIS, which can often be more widespread than invasive tumors?
Right. So DCIS is a very, interesting problem. It's not invasive cancer. It's potentially curable with just removal. By dealing with it when it's DCIS, it never has a chance. If you deal with it effectively as DCIS, it never has a chance to develop into an invasive cancer. But one of the challenges is that it's just hard to see because it starts off as often something that is not ultrasound visible. It might only be detectable because it has calcium deposits associated with it. And so because it is not usually ultrasound visible, it's a hard or challenging target. There are some workarounds that we've developed. One of the workarounds is that, as I described earlier, we can place at the site of the DCIS an ultrasound visible marker. that can then be used to aim the cryoprobe. So you can convert this thing that is not visible generally with ultrasound to something that is visible indirectly by ultrasound to target it. So if it's a small enough area, a single ablation for most DCS lesions under 2 centimeters will be rather easily managed with cryoablation. The challenge as well with DCS is that it sometimes is larger than 2 centimeters, and sometimes it's just not well seen by imaging in these imaging studies. And so there's a higher risk that it might be incompletely treated. So because of that, we have to treat with a larger volume of ablation. So instead of accepting a small margin of invasive around an invasive cancer that you can see very well, because DCS is often underestimated by its size, we generally want to add a wider margin around the DCS to have more confidence that we can treat it with a clear margin. Now, thanks to your efforts and the support of many people who are listening to this webinar, we were able to raise funds to support a trial, which we didn't have a question about it, but I'll just elaborate a little bit more. It was a study that was co-sponsored by the Helen Reed Breast Cancer Foundation with support from doTERRA and support from the Corey Foundation as well. Brought together funds to do a study of patients with small areas of DCS under 2 centimeters. The concept here is to examine the ability of cryoablation to treat DCS effectively. We've been using it in a way that's sort of hypothetical, meaning it makes sense that would work, but we really haven't formally studied it. This would be the first formal study of it. The concept is, for the trial, is that the patients that participate, those with DCS measuring 2 centimeters or less by imaging, would undergo cryoablation, a single treatment, and then 6 months later, they would undergo a core biopsy of the cryoablation site to document that the area has been completely ablated. It's a way to prove definitively that cryoablation works for DCS. We've done those studies for invasive cancer. They haven't been done for DCS. It makes even though DCS is a challenge for cryoablation, it makes a lot more sense to develop cryoablation as an option for DCS because it's a non-aggressive problem that should be managed ideally with a non-aggressive solution, and cryoablation may prove to be that.
You have to put a marker in, and I have a question about the marker. Does it have to be metal, or can you just have the collagen basket?
Well, all of the markers that are commercially available now have a metal part. Now, most don't have an ultrasound visible part, but there are a few that have an ultrasound visible part, and those are the ones that we select for the placement. Most of the markers are made of steel, so they're not reactive. Some are made of nitinol or nickel, and those may be problematic, but we don't use those markers for our cryoablation patients. So choosing the right marker, which has an ultrasound visible part, it's critical for patients that don't have an ultrasound visible DCS, which is most.
At what point is the DCIS too big for the cryoablation?
Well, that 11 centimeter case was a case of DCS.
Oh, okay.
Yes. And I felt it was too big, but that was really the only option that the patient was willing to accept. And so we used a total of, I think, 10 ablations to cover the entire area with a margin. Again, with the understanding that the patient would receive radiotherapy subsequently, because DCS doesn't always reveal itself. And even though we targeted what we could see, and we assumed it was 11 centimeters by imaging, it could have been 13 and 14 centimeters in reality. And radiation or something more was needed to compensate for the invisible parts. But, with that, and with placement of multiple markers so that I have basically a roadmap to target, we're able to sort of extend the limit. Again, this is not the ideal treatment for this problem. It's a better solution for a small area that can be treated with 1 at most 2 ablations. But on a case-by-case basis, when the patient is unwilling to opt for conventional therapy, we can make a decision to do so. There is a case I want to just mention where, this was I think it was a 10 centimeter area of DCS, where the thought was going into the procedure was that it was only DCS. But usually when we have such large DCS lesions, I insist on biopsying it in other areas just to make sure that the other areas are DCS. In this particular case, several areas had invasive cancer as well. So it already started the transition. So leaving it untreated and assuming it's not going to get worse just because it was once DCS doesn't mean it will always remain DCS. And so, out of kind of concern for the risk of progression, I've been willing to treat some situations that were not best treated with cryoablation, would have been more appropriate treated with surgery or even mastectomy. But again, it's on the case-by-case basis.
Does DCIS respond well to cryo? I guess that we'll figure that out in the trial.
Right. I mean, the assumption is that it does, and the assumption is based on the fact that most invasive cancers have coexisting DCS. About half of them have detectable coexisting DCS. And when we biopsy the invasive cancer 6 months later, we don't find living DCS or invasive cancer. So one can conclude that it appears to be working well against both. But we've never done a study of pure DCS yet, and now we will. By the way, that study was submitted to the IRB. It passed the first review. I had to submit responses to some of the questions, which I did last week. And so it was supposed to up for second review this month. And if it is approved, then we'll be able to open the study next month.
Oh, nice. Okay, how many probes do larger lesions require? Because this particular person was asking because they're trying to figure out how to determine the cost.
Well, there are two questions there. One is that, the more ablations, the more cost. So that's the background to the question. But the challenge is that, each ablation is limited to this. And in order to effectively ablate a larger tumor and not leave gaps between ablation zones, we have to actually overlap the ablations. It's not sufficient to do it this way because then there'll be, within each of these gaps, you might leave disease. So we actually have to overlap them so that's more like that. And the actual distance from probe to probe is about 15 to 17 millimeters. So that's multiple insertions, each about 15 millimeters apart.
And each one needs a new probe?
No, we use,
Okay.
each probe can be used up to 3 times, 2 to 3 times, and then it has to be replaced. So we end up having to go through multiple probes as needed. But it's, and so just in case you haven't seen one, this is actually a cryo probe. This is the working end. And so we would have to insert this at various intervals. So we really have to kind of map out the disease. And sometimes it's not just in one plane, but if it's a thick tumor, it's in 2 planes. You have to treat one layer because you can only get a 3 centimeter diameter. But if it's a 4 centimeter tumor in thickness, then you have to have another layer. So that's kind of where the complexity and expertise come in, and why so few people do this, because you have to really kind of have an organized understanding of the extent, if there are little arms or extensions or things sticking off the main tumor, and build the zone around it so that you can accomplish that. And to be frank, the study that best shows a 3-dimensional anatomy of a tumor is breast MRI, because you see these sort of additional things. They're not all round or square. They're quite irregular. And so knowing where the irregularities are allows me to shape the cryoablation zone, or sometimes, rotate it so that I'm not treating this way, but this way or this way, to encompass something that isn't simply round or square.
With DCIS stage 0, intermediate grade, do you need an MRI to be treated with cryoablation?
Not a requirement, but it depends upon how it presents. I mean, ideally, if it's intermediate grade, it has calcifications that were detected on the mammogram. If it's a fatty breast with no suggestion of potentially other disease around it, you can have more confidence that cryoablation will work without an MRI. If the breast is dense, or if there's any suggestion that there's extension beyond the calcifications, then MRI would have more value.
That's a loaded question. Does a mastectomy actually prevent breast cancer? I've heard of a lot of reoccurrences.
Well, the sad truth is that you can have a recurrence after any procedure. It's largely an issue of the anatomy of the tumor, like where it is and what you treated, how much tissue you ablated or removed surgically. And that is also true with mastectomy. even though a mastectomy is performed, we always leave some breast tissue under the skin. And sometimes there are tumor cells in the lymphatics of the breast tissue or in the blood vessels of the breast tissue or along the chest wall. And if those areas aren't removed as part of the mastectomy procedure, which they generally aren't, because we always leave skin and some tissue behind, then those areas can be a source of recurrence. There are low risk situations. So most people are low risk for recurrence after mastectomy. Low risk meaning that they have a risk of recurrence in the range of about 2 to 4% over 10 to 20 years at the mastectomy site. But some people have high risks of recurrence, like those that have tumors that involve the skin, or they have breast edema where swelling is a part of the cancer presentation, or skin redness is a part of it, or if they have multiple positive nodes. All of those things are risk factors of recurrence even after mastectomy. That's why often those patients are advised to have radiation after mastectomy, because we know that they have not a 2 to 4, but a 10 to 15% risk of recurrence at the mastectomy site. So mastectomy isn't perfect. It is a good solution for many problems, but no one should go into it thinking that they have zero risk of recurrence. That is not true. It's usually in a range of about 2 to 4% for the average situation, or 10 to 15 for high risk situation.
Can you do armpit lymph nodes with cryo? And they said, can you speak a little bit on cryoablation and lymph nodes? The doctor says I have 4 to 5 abnormal lymph nodes and wondering if it can be taken care of with cryoablation, and how you would treat patients with node involvement.
Yeah, so that's another new frontier. I mean, a few of us have felt comfortable treating lymph nodes, but it's under specific circumstances. First of all, we generally want to limit it to patients with 1 or 2 lymph nodes, because unlike the breast, the lymph node area has some important structures surrounding it. There are large vessels in the underarm area. There are some large nerves in the underarm area, and there are a lot of lymphatics. And so to treat a large volume of tissue in the armpit can potentially injure any of those structures or cause lymphedema or swelling, because we're randomly ablating, crossing lymphatic vessels. So even though you can think of it as targeted treatment, it is targeted in some ways, but also indiscriminate in other ways, because if anything that's adjacent to the lymph node in that small area can be injured. So I have performed cryoablation for lymph nodes, but I think it's best for one situation where there's only 1 or 2 lymph nodes, so we can limit the area of ablation. Number 2, treating lymph nodes that are lower in the armpit area as opposed to high up near the veins, so that we can avoid injury to the vessels, and also avoid the lymphatics that are more prominently located in that location. And number 3 is I really emphasize the fact that just because you only see 1 abnormal node doesn't mean that you only have 1 abnormal node. Likely, there's a 30 or 40% chance or higher that you have other nodes that contain cancer. It's just that only 1 looks abnormal now. But in 2 years, you'll see another show up. So the cryoablation just is appropriate for dealing with the gross disease. There's still treatment needed for the other nodes. And so I try to get most patients to agree to have, if they're opting for cryoablation of the lymph node, I try to get them to agree to have radiation of the lymph node area, because radiation is very effective at treating microscopic nodal disease. And it's also safer than surgery. There's a lower risk of lymphedema, less pain, less complications with radiation. So combining a targeted cryoablation to 1, at most 2 nodes, and irradiating the rest is actually a very good treatment. I mean, all indications would be that works very well together. But ablating 4 to 5 nodes actually, I think, will be more injurious than the radiation approach.
What does follow-up care look like for patients that come in from out of the area or out of state? How do they get their biopsy scans, et cetera, to confirm NED? And do you have a list of like radiologists who can read post-cryoablation scans for out-of-state patients?
Well, as you know, many of our patients do come from out of state, and so we try to make that process as easy as possible for them. Obviously, it starts with initial consultation, which can be a telehealth visit, where prior to the call, they submit their reports and imaging studies. I preview them. We can let them know if cryoablation is even feasible, or maybe they want to talk about surgery instead. If they do wish to have the telehealth consultation, we set that up and go through, their anatomy, their problem, their treatment options, including cryoablation if appropriate. And then if they decide to proceed with cryoablation in this example, then we usually have them come in on a Tuesday. We generally perform cryoablation on Wednesdays and now Thursdays. And then one day after cryoablation, they're able to travel home. So they need to be on the ground for 2 to 3 days typically. We then set up a telehealth follow-up visit 2 weeks later. And I recommend imaging at 6 months. Ideally, mammogram, ultrasound, and MRI, although not everyone is willing to do all three. I also recommend the biopsy of the cryoablation site at that time point as well, because as you know, everyone will be left with a lump. That lump will often be a cause of anxiety, at least amongst their physicians. Giving everyone the proof that the area has been completely ablated is really reassuring. So a biopsy helps accomplish that. You did acknowledge that sometimes it's hard to get someone to read the studies with confidence because most radiologists are unfamiliar with looking at post-cryoablation mammograms, ultrasounds, and MRI. So I give patients two options. Number one is to have their studies performed near their home and then have them sent to more experienced radiologists for a second review. That will give them more confidence about the interpretation. Alternative is for them to come back to California, to Los Angeles, and they can have their imaging performed and interpreted by an experienced radiologist. We have not a published list, but a list of radiologists that locally, but also some out of state that have more confidence in reading cryoablation because either they do the procedure or they have experience with interpreting it. And so we can help guide you to, someone who can give you a confident reading and perform the appropriate imaging studies. And generally speaking, I continue to follow the patients on a yearly basis. We also want to make sure and at least encourage for them to proceed with the other parts of their care, which would be important. For example, taking anti-estrogen therapy if appropriate, or chemotherapy if it's appropriate, or radiotherapy is appropriate, or anti-HER2 therapy. Yes, exactly, as you know. So it's not just doing the procedure, but trying to provide, comprehensive care, or at least facilitate comprehensive care for problems that often need more than just cryoablation.
How common is it to still have pain 2 years out from having cryoablation?
I say that it's uncommon to have pain that is significant. Now, after any breast surgical procedure, there's a pattern of pain that one can generally expect. There's usually tenderness to pressure on the site, and there may be occasional stabbing pains at the site. And those are ways that the breast can heal. And depending upon how the breast heals, you may have more or less of that. One of the ways that the breast can heal after cryoablation is to have fat necrosis form. Fat necrosis is what happens when fat dies. Fat necrosis matures in multiple ways, but one of the ways that it matures is with some inflammation. And sometimes it forms a hard mass or a firm mass that persists, lasts maybe indefinitely. Fat necrosis tends to be tender. So if you press on the site, it might be the cause. Fat necrosis is more common in fatty breasts, less likely in dense breasts. So it's kind of dependent based on how the breast heals. But to answer your question, it is possible that someone years later can have a tender area after either lumpectomy or cryoablation, and it's likely because of some post-treatment effect that indicates that the healing process hasn't ended completely.
Why don't you take insurance for cryoablation?
It's a good question. So the main answer is that there is not currently an established reimbursement for cryoablation. That's the simplest answer to the question. There is a code that was recently established for invasive breast cancer. The code is more kind of for a tracking code just to see how often it's used. That is usually followed a few years later by a process which assigns value to the code. The other limitation of the code, however, is that the code only permits you to charge for one ablation per breast. So even though you may need to use multiple probes or treat multiple sites with one probe, the code doesn't allow you to bill for more than one procedure. So the code really doesn't reflect the problem. Even when, if there were value to it, it wouldn't really affect the problems that we often encounter. It also doesn't account for the fact that, you know, the problems that we encounter are often quite complex in terms of the planning, complex in terms of the treatment, and it doesn't account for the resources that we use to perform the procedure. I use 2 to 3 people in procedures, so the code doesn't take into account that that is needed. So ultimately it comes down to what is the cost for us to do the procedure in terms of personnel, equipment, and time, and what does the health plans allow? Health plans don't cover it. Likely when they cover it, they won't cover it at the appropriate rate for a complex tumor. They might cover it at an appropriate rate for a simple tumor. And so it's sort of an evolving thing. What we can't do is accept the risk of billing for insurance and not being reimbursed and then trying to get paid for the procedure later. It's just there's too much exposure and the procedures are too sort of expensive to do to accept that risk. So the only way we can do it in the way that sort of it protects us financially is to charge for the procedure up front and then provide patients documentation to seek reimbursement from the health plan.
Which in my case, Medicare did reimburse me.
Right,
Partially, they reimbursed me
right.
for 1 tumor. I had 2.
So that's the reality of where we are now. One day things will change. One day there will be a code, but that code will cover very specific situations. It will cover women that have a single ablation, that need a single ablation for a tumor that's 2 centimeters or less, and it'll be invasive cancers. So it'll be a very narrow group that's approved. Often what we're treating are people that don't fall into that group.
They can always bill like I did and get whatever they
Right.
can get.
And we'll
And I
help that
do-
process.
I do now have the name of a person who can do third-party billing, so I can help them out a little bit with that.
Great. So you hear that here. So reach out to Sharon
Yeah,
if
I
you're
already talked to her, and
Yes.
in fact, her name is Sharon as well, but it's not me. Will you do a tumor that's ductal with lobular features or one that's triple negative, and if not, why?
right. So this is one of these examples of sort of how the real world and what likely will be permitted. I suspect that when cryoablation does become accepted and as a procedure that's covered by insurance with an appropriate reimbursement, it'll be limited to the most conservative cases, small tumors that are non-aggressive, that have less need for radiation and no need for chemotherapy, and that don't have lymph node involvement, which is probably the right place to start. What it won't cover are tumors that have lobular features, because they tend to be a little bit more complicated in terms of the size, and it won't cover triple negative tumors, which are high grade. It won't cover HER2 positive tumors, which are more aggressive and need chemotherapy. That's kind of likely where we're going. And so, but the question isn't so much can it treat those, is can you find the right patients, the right tumors, and approach it with the right solution in order to address it. So let's start with the ductal with lobular features. Ductal tumors tend to be more compact. They tend to reflect, the imaging tends to reflect what is truly present there. You can verify that with surgery. If it looks like it's about 2 centimeters, usually it's about 2-ish centimeters. Lobular tumors or tumors with lobular features often are underestimated by imaging. They might look like they're 2 centimeters, but they might be 6 centimeters. They might be 8 centimeters, because they have this pattern of growth where they kind of like blend into the surrounding tissue. So you really have to select those patients really well. And then when you select them, you have to really treat them with a wider margin than you would otherwise treat a smaller tumor, because the imaging often underestimates it. MRI helps, but even MRI can underestimate it. Now, all the trials looking at cryoablation have been primarily trials of non-aggressive low-grade tumors. So triple negatives were excluded, HER2 positives were excluded, but it doesn't mean that it doesn't work against them. It's just a matter of the anatomy. So I've treated patients with triple negative breast cancers with cryoablation very effectively. I've also treated patients with HER2 positives.
I was HER2.
What it's not an issue of cryoablation. I think of it this way: if you can remove it with a lumpectomy of any size, you can treat with cryoablation with one or more cryoablations. It's just a matter of the anatomy. What is true about the triple negatives and HER2 positives is that often other things are needed. So people shouldn't assume that a cryoablation will solve all problems. Triple negatives often need chemotherapy. HER2 positives generally need anti-HER2 therapy and chemotherapy, generally speaking. So although I'm willing to offer them cryoablation to treat the tumor site, they have to understand that those tumors have a high risk of spread and that the comprehensive treatment requires some kind of systemic therapy in order to minimize the risk of recurrence.
What's the difference between NED, remission, and cancer-free, and why do they say NED versus cured? And does a clear PET scan equal NED?
So NED is no evidence of disease. And it simply means that it's no evidence of disease. It's like saying, I have no proof that you're lying. It doesn't mean that you're not lying. Right. It's mean that you can do a mammogram, you can do an ultrasound, you can do a PET scan, and if there's no disease detectable, we say that there's no evidence of disease. It doesn't mean that there's not disease present. It just is not detectable yet. And there's always a point at which disease is not detectable in the various early stage. So we never quite want to say it's a cure because we don't truly know that there's not a single tumor cell sitting in the liver or a single cell in the bone that's too small to be seen by imaging. So although we like to say cure, we know the reality of breast cancer or cancer generally is that you can't really say cure based on imaging. It's really more a function of time. So if you go a long period of time, 5-10 years, and there's no recurrence, meaning those cells that might have been present haven't grown, then we feel more confident in saying cure after a long period of time. But even then, cancers can occur late. So that's why it's kind of safest for us to say there's no evidence of disease, because we know that, cancers can be present but undetectable. And sometimes they may be present for a very long time before they become detectable. So cure is a little bit too strong of a statement, especially for breast cancers, which, the aggressive breast cancers tend to occur early. The non-aggressive breast cancers, if they recur, may recur in 5 or 10 or 15 years. So that's why we just can't say 5 years if it's not back, we should consider the cure, or 10 years if it's not back, we should consider the cure because of these potential late recurrences.
Just live like you don't have it and see what happens.
Right. I mean, if it becomes sort of a thing that you manage with chronic management, either with medications or lifestyle, then it's can be like diabetes or hypertension or whatever. Doesn't mean that you ever cure it, but you can manage it through your natural life so that it never develops enough to be life limiting. That's not the ideal, but that's better than the alternative of having it come back and grow. So, these low-grade tumors, even though they recur late, they're still very well managed so that they may not end up limiting someone's lifespan.
Is there an alternative way to confirm NED other than a biopsy? We judge NED based on imaging. If there is a finding that is seen that's suspected as a possible recurrence, then the only way to prove that that's not with confidence is to biopsy it. But if there's no target, if there's no thing to see or to follow, then we'll conclude it's NED and hope that that remains the case, that all subsequent imaging will show no evidence of recurrence. What's the best way to monitor whether cancer is still in the body after surgery or a cryo? CTC test or something else? Circulating tumor cells test?
We don't know the answer to the question. It's never been tested. In fact, we don't really, circulating tumor cells has not been widely adopted as a screening tool, partly because although it is detectable and you can respond to it, we don't exactly know what it means. I mean, we don't know if any cells means that you should treat, or if there's no cells, that means you shouldn't treat, and is circulating tumor cells, does it fluctuate? So we don't, so it hasn't really been integrated widespread as a way of tracking for recurrence. It's used more as sort of, I know it is used, but let's just say that we don't have the amount of confidence that we would like to have it to say that every patient should have a CTC, circulating tumor cells, monitored to screen for recurrence. So the question is, well, how else can we screen? Well, for the most part, we screen based upon anatomy with imaging, meaning that we look for changes either mass or calcifications or changes in enhancement that indicate that something has changed about the breast anatomy. And then we perform a biopsy of that. But I think that, the circulating tumor cells is an interesting way to look at the problem. It just needs to be formally tested to see if it's predictive. We also don't know, if the tumor cells or circulating tumor cells levels go up, we don't really know where it comes from. Does it come from the breast? Does it come from another site? And so sometimes, you're chasing something that you can't identify because you don't know where it comes from. The biopsy in the breast might be negative, but if the cells are elevated and your scans are otherwise normal, like your PET scan is normal, how do you deal with that therapeutically? Don't know the answer to the question.
So then the next question about how worried should you be about circulating tumor cells is kind of a moot point.
I think it's a cause for worry, but it's like, you worry about a lot of things and but you don't know what to do about them. And this might be one. So I say, if you're doing something, this is kind of like my opinion. It's not based upon fact. Just my opinion is, if you opt to monitor it, and if it goes up, then I think it's a cause for worry, and someone should look for a source of recurrence. And if you're concerned about the elevating and you haven't opted for conventional therapy, then maybe it's a reason to consider it. Or if you haven't been following the right lifestyle approaches, then maybe it's a reason to start to do it. So it is a cause for action, whatever that action is, either to scan or to treat better or to improve the lifestyle. But just because they're not circulating doesn't mean that you shouldn't do those things either, because we don't know that negative circulating tumor cells doesn't mean that there's no risk of recurrence. It doesn't necessarily mean that. So a negative result doesn't mean that you shouldn't act, but I think a positive result definitely means you should do something different than you've been doing before.
Is there a less invasive way of checking the lymph nodes other than a biopsy?
Well, the less invasive ways are with imaging. So with ultrasound being the most sensitive way, because we can look at the shape and the size of the node with a little bit more precision than with the other studies. But a normal looking node doesn't mean that it's absolutely normal, because a situation where there could be no evidence of disease, but there could be some microscopic disease. So traditionally, we would perform a lymph node biopsy for women that are undergoing surgery just to remove the node to see if it has cancer. We call it a sentinel node biopsy procedure. If, however, the lymph nodes are normal, so in some situations, lymph node looks normal, but we biopsy and we find that it's positive, and then we act upon that. For cryoablation, we don't generally have the option of performing a lymph node biopsy, so we rely upon imaging more. But there are situations, particularly for the higher risk tumors, where I think imaging isn't good enough, like a triple negative tumor or HER2 positive tumors. They have a high risk of spread, and even if the lymph node looks normal, I think it helps to have a little bit more confidence that the lymph nodes are not affected. So for those patients, I generally recommend, even if they're having cryoablation of the breast, I recommend a lymph node biopsy, removal of the lymph node, because there is the potential that we can have undetected disease there that will recur and become a bigger problem to treat later. In addition, knowing that whether or not they're node positive affects the kind of systemic therapy they get. So watchful waiting doesn't work as well now. Now, that doesn't mean that I don't ever agree to do that, but the preferred thing for those patients with high risk disease is to perform a lymph node biopsy. If they're unwilling to do so, then, and I mean a surgical biopsy, if they're unwilling to do so, then we follow them with imaging to see if they have an abnormal appearing node that develops. If they do, then we would recommend a needle biopsy of that node.
What if it's HER2 and you get Herceptin?
Well, the sentinel biopsy is still preferred, but if they're not opting for it, then at least I'm reassured that they're getting Herceptin, because if they are, then if there's microscopic disease in a node, the node should respond, and then we can follow those patients. I have had patients with HER2 positive disease that had nodes that were abnormal initially, that were detectably abnormal initially, that responded to the drug therapy, which one would hope, but didn't respond completely, and then started to regrow after they finished Herceptin. and then we had to deal with it with an invasive procedure. So the medication doesn't always work perfectly, or at least once you stop it, if there was surviving cells, they may regrow. So sometimes the nodes still need to have a definitive procedure, even if you're taking medication. And cryoablation of a node might be appropriate on a case-by-case basis, or surgical removal as well.
I'm having a follow-up breast ultrasound and want to know if the tumor has grown. Will I need a biopsy before I schedule a cryoablation? If I do, is there anything special that needs to be done, or any special need with the biopsy before you can do the cryo?
Well, I don't fully understand the circumstances. Obviously, they're doing some kind of treatment there, I suppose, because they're trying to see if the tumor is regrown. But I think, pre-cryoablation, sometimes people opt for like naturopathic methods to see if they can get the tumor to respond. And then they do ultrasound to follow up. Or sometimes you use preoperative chemotherapy to shrink the tumor with a plan possibly to cryoablation later. In both situations, I think that if you're thinking about pre-treatment prior to cryoablation or treatment after cryoablation, I think it's best to treat with cryoablation first, meaning that not pre-treat with lifestyle or pre-treat with medication and then ablate, but to rather do the ablation and then follow it with the lifestyle changes. The reason being is that often, even though tumor responds grossly, it might not respond completely microscopically in those places. So it might shrink, but it might leave tumor cells in the wake as it gets smaller. And so I feel compelled in those situations to not treat the current volume, but the original volume. So taking 6 months of pre-treatment to see if you can shrink it, or taking chemotherapy to see if you can shrink it, won't necessarily change what we target with cryoablation.
I think though what they were actually asking was if they had a follow-up ultrasound and then they needed a biopsy, is there anything special that needs to be done in the biopsy, or the biopsy just
This
biopsy?
is follow-up ultrasound after they've already had cryoablation? Is that?
No, they're saying follow-up breast ultrasound and wanting, this is before. They have a follow-up ultrasound to see if the tumor's grown from, I guess, the previous ultrasound. And then they need do they need a biopsy before they schedule the cryoablation?
No,
and if so, is there anything special about the biopsy that needs to be done? So
if they've already been biopsied, like they originally had a biopsy, which established an invasive cancer diagnosis, then they don't need to have another biopsy performed prior to cryoablation. You can perform ultrasound to look at the current size, but you don't need to re-biopsy. There are people that have tumors that have not been biopsied. Maybe they had a fear
Like
about
mine.
the biopsy.
My second one that you found?
And then the tumor, is then managed in some way, lifestyle, whatever. And then they come for cryoablation, even though they might have an ultrasound that's shown that it's increased or decreased in size, I still would want them to have a biopsy done, but we can perform that biopsy at the time of cryoablation. So it's not needed to be performed at the time of their ultrasound. It can be performed as part of the cryoablation procedure. It is certainly their choice to have it performed, but for the cryoablation procedure. But if they're concerned about, seeding or some other aspect of the biopsy experience, that biopsy can be combined with the cryoablation procedure so that it's all done at one setting, where we basically insert the needle to take the sample out, and then insert the probe to the same needle track to perform the cryoablation.
What are your thoughts on cryoablation for skin metastasis?
Well, I know there's some technology for that, but it's not really well developed for breast cancer metastasis. The ones that are primarily appropriate for skin just treat the surface of the skin. And so it isn't really a full thickness skin treatment. For skin metastasis from breast cancer or other cancers, it's a full thickness problem that requires a full thickness ablation. And if you ablate the skin full thickness, it'll create a sore that will need to take some time to heal. And it might be a few months. So generally speaking, if it's an isolated skin metastasis, I think surgical excision makes more sense. But you also need to have more than that, because usually if there's one metastasis in the skin, it's only a matter of time before others will show up. So excising the known problem and irradiating the surrounding skin is usually the best solution to control the problem.
What's your thoughts on fat necrosis? Is it necessary to operate it or not?
It's never really necessary to operate on fat necrosis unless it's symptomatic and it's something that you just can't tolerate. Usually fat necrosis is symptomatic. It can be tender, but usually just tender to pressure. But if it is, significantly altering your quality of life, where you'd rather have surgery than deal with a tender area, then certainly operating is an option. Operation can also cause some fat necrosis as well. So it's not a perfect solution to it, but if it's a discrete area of fat necrosis that you can cut out, and if the surrounding tissue is healthy and is likely to heal well, then I think surgical removal of fat necrosis is reasonable.
How necessary is radiation with a 13 centimeter tumor with clear margin mastectomy, 41 nodes positive, stage 3? Very
necessary. And it's part of the issue that even though they can remove the cancer and the nodes, in such a situation, there's likely a lot of lymphatic disease remaining. If there's remaining skin, if there's remaining chest muscle, if there's remaining fat under the skin, there are lymphatic vessels that travel through that. And when you have so many nodes involved, usually there are cancer cells that are backed up in the lymphatics of the breast area that will recur, be the source of recurrence if you don't irradiate. So I would put the risk of recurrence in the 50 to 60% chance in that case, if not higher.
What percentage of women do you see for breast cancer surgery that come back with a recurrence?
I see a fair amount. It kind of depends though. I always share with patients, whether they're choosing lumpectomy or cryoablation or mastectomy, that it's only one of a number of the treatments that may be appropriate for a particular problem. If it's a high-grade tumor, HER2-positive tumors, cryoablation is just one treatment, but you might need radiation, you might need drug therapy. And that's true for all the situations. And so, whether or not a patient opts to have radiation or opts to have chemotherapy or anti-estrogen therapy, I can't exactly control that. I can certainly make the recommendations, but I deal with a lot of patients that are very clear that they don't want to do certain things. And so that comes with some trade-off, and that trade-off may be a higher risk of recurrence. So we try to get them to the point where they can have the lowest risk of recurrence. That means have them well imaged, so we have a good sense of the problem, treat it with a wide margin. If they require or would benefit from anti-estrogen medication, recommending it. If they would benefit from radiation, recommending it. If they would benefit from chemotherapy, recommending it. But if they opt to do none of those things, then there has to be an understanding that you're willing to accept the higher risk of recurrence. So it's hard for me to say that I have a risk of recurrence that is X, because all the situations matter. But I give everyone an estimate. If you have a tumor of a certain size and you treat it with cryoablation alone, this is your risk of recurrence in 10 years. If you had radiation, this is your risk of recurrence 2/3 lower. If you have medication, it's half of that. So you go from, say, 10 to 2% with all three versus just 10% with cryoablation alone, or 3% with radiation added, or 1 to 2% with medication added.
Can a non-healing wound post-lumpectomy, DCIS, non-invasive, turn malignant in the future?
It can. So one of the questions when you have a non-healing wound after cancer surgery is it actually an indication of recurrence? Sometimes the recurrence happens in the scar, and so you think it's just a non-healing wound and it's actually tumor itself. So that's one concern. You have to exclude recurrence. But there can be areas of fat necrosis inside where it forms a fistula to the skin, meaning a tract to the skin that becomes chronically healed. We call it epithelialized. It forms a fistula, so it doesn't heal; it just kind of drains, and that's a chronic wound problem that may never heal. It might take a long time to heal. There's always a concern that there's a long if there's a non-healing chronic wound, that either it's a breast cancer recurrence or it's a squamous cancer, a skin cancer that is formed from chronic irritation. So the first goal is to rule out recurrence. And once you do, then it generally can be managed with some definitive excision and reclosure procedure.
What are your thoughts on a positive equivocal HER2 status that has a negligible response to target therapy?
I think I was not quite clear on what was meant by that question, but I'll address it to some degree. So a positive, when someone has HER2 testing, you can either get a positive result, a negative result, or an equivocal result. Positive means that there's enough signal that's detected that's clear enough that it would benefit from anti-HER2 therapy. Negative means that you have a normal level of HER2 where there's no benefit from anti-HER2 therapy, or there's equivocal, meaning that the test is in between. And so whenever you get an in between or an equivocal result by immunohistochemistry, which is a test that we're referring to, we usually perform a confirmatory test called FISH, which will then determine if that equivocal is truly positive or truly negative, or amplified or non-amplified. So we never get to the point where we have no answer. Equivocal is usually resolved as either amplified or non-amplified, which is the same as positive or negative. But sometimes you have to go through this intermediary test. So if it's positive or if it's amplified, it benefits from anti-HER2 therapy. If it's negative or non-amplified, it does not benefit from anti-HER2 therapy.
It's Paget's disease of the breast, a type of autoimmune disease as well as a type of cancer. Is there a link between Paget's and lichen sclerosis? The symptoms are really similar, just in a different area of the body.
So I'm going to give you a short answer now and a long answer later. The short answer is that they're different. Paget's is a manifestation of a cancer that involves the skin of the nipple and possibly areola and sometimes beyond. The other things are benign, but sometimes they have a similar appearance and which can be confused. We actually have written a paper on the topic. It's undergoing its final edits this week. I plan to share a copy with you because you made a contribution to it, which I won't elaborate on, but you'll get to read about it. And then we'll publish it. We have a journal that's agreed to publish it. And so the readers will be able to get a copy of it. And basically we talked about what Paget's is. And we also talk about the differential diagnosis of the things that can be confused and by it, with it. But the take-home message is that it's a malignancy that requires a cancer treatment. The other things are benign and can be managed in other ways.
I'm glad you read the paper. I got misdiagnosed a bunch of times.
Yes.
How long can one expect to have breast pain after a lumpectomy and lymph node removal, especially since developing a seroma after lumpectomy? How long is it considered immune compromised after the breast cancer diagnosis?
Well, I'll focus on the first part of the question because I can't quite address the second one adequately. But similar to the explanation I gave about cryoablation, there can be post changes after lumpectomy that can be the source of tenderness or pain for months or years later. It kind of depends upon how it heals. One way that lumpectomy heals is that it can heal with a seroma, meaning that there's a cavity that contains chronic fluid that may persist for a number of years. And sometimes seromas are tender. Most times they're not, but sometimes they're tender. It just depends upon how distended they are. And so that can be a source of chronic pain. One way you manage it is simply to suck out the fluid. Sometimes it comes back and requires repeated aspirations, but seroma is a natural way of healing, and lumpectomy is healed that way. And sometimes for some people it's more sore. With cryoablation, we don't have a cavity, so there's no seroma. So at least there's one that doesn't happen with cryoablation. That's one advantage. But lymph node surgery as well, you can have the most common problem early after lymph node surgery is seroma there as well. Fluid collecting in the area, again, can be managed with aspiration. Sometimes there's chronic pain with scarring or chronic pain related to nerve injuries that occur during the lymph node procedure.
What sort of pain is normal a year out from mastectomy with no reconstruction and some lymph node removal? Are intermittent stabbing type pains normal under the arm and throughout the mastectomy site? It's tolerable but worrisome because there's always a fear of cancer returning.
Right. So I mentioned that earlier. After any breast procedure, whether it's a needle biopsy, or cryoablation, or lumpectomy, or mastectomy, the pattern of healing that we see with the breast is that there are occasional stabbing pains that happen in the wound.
Yeah, I'm still getting some of those.
Yeah. See,
From the cryo.
exactly. So we remove the breast, but the nerve roots are still alive. And there's still signals that occasionally come down towards the chest wall that are perceived as sometimes electrical or shocking pains that come out of the blue. Nothing prompts them. They just kind of random event. I always reassure patients, I just try to reassure them that it's normal. It happens, it can last for years, although it usually diminishes. It's not usually a point area that you can put your finger on. I mean, this pattern of pain. There are patterns of pain that can be point tenderness, and that's because sometimes the nerves can develop little, what we call neuromas. So if there's one spot that's always really sore, it might be because you have a neuroma at that spot. That's a different kind of pain than this occasional, electrical pain. But chronic mastectomy pain is a recognized thing. And it can be either that or from stiffness or scarring. And sometimes you need therapy to loosen up the tissues or to deal with neuromas so that they don't remain the source of chronic pain.
Can chemotherapy and off-label drugs reduce cancer and auxiliary nodes enough to not need surgery to remove the nodes? Lymph nodes.
So yes, sort of no. I mean, we have been utilizing neoadjuvant chemotherapy, chemotherapy given prior to surgery to downstage patients with positive nodes. So patients that have clear evidence of lymph involvement that is treated with the chemotherapy. If the chemotherapy is really effective, then those nodes can be converted to negative nodes. And the current convention is that if we perform a lymph node biopsy and remove 2 or 3 of those nodes and prove that 2 or 3 of those nodes are now negative, then we feel comfortable with leaving behind the rest of the lymph nodes, because if the ones that were clearly positive before are now negative, we can have more confidence that the others are probably clear, and therefore we don't need to remove them. So that is what we're doing now, but it still does require that we kind of prove with a tissue sample that the nodes that the chemotherapy worked perfectly. And so we do less extensive lymph node removal, but we haven't gotten to the point where we perform no lymph node removal. Maybe we'll get there, but we have to have a lot more confidence that the chemotherapy is working.
What is the statistical percentage of an ER/PR positive breast cancer recurrence for a person 47, generally fit, healthy and normal BMI, dairy-free, never smoked, does intermittent fasting? I mean, healthy as all get out. Very limited alcohol intake if tamifloxacin is refused.
If tamoxifen is refused.
Rather.
So I don't know. But it depends upon sort of, so you start with knowing some additional details about the tumor. And so for someone with estrogen receptor positive tumor, which is what she obviously has, we commonly do genomic testing. Genomic testing is a test performed of the tumor, which help us estimate the 5 or 10-year risk of recurrence within the body. And that includes not just the breast, but the lymph nodes and elsewhere. And that number varies per person. So if you want to give an answer that's true for that individual, then her tumor should undergo genomic testing. It will give her a 10-year or 5-year risk of recurrence. And based upon that, you can then calculate what the benefit is of taking anti-estrogen therapy or what the benefit is of taking chemotherapy. You can actually do the math. Generally speaking, tamoxifen reduces the risk of recurrence by 40 to 50%. So whatever that number is, if you take tamoxifen, it'll reduce it by about 40 to 50%. So that's why I can't give her a specific answer, but she can get a specific answer by asking for genomic testing of her tumor, which still likely exists in the lab, and that'll come back as a report, and then you can make a calculation. I often do genomic testing because I work with a lot of patients that may or may not want to use conventional therapy, But in order for you to make an informed decision about not taking something, you really know what risk you're starting with. If you have a high risk, you might reconsider not taking it. If you have a low risk, you might decide, well, my benefit is so low, why bother? But you can't really make that until you have some sense of the true risk.
For lobular carcinomas, how do you improve the E-coherin loss associated with the lobula and the supplement? And what supplements should you take for E?
So E-coherin. So
and what and ER positive 100%, and what should you avoid?
That's a complicated question. So I'll just say that E-coherin is basically a protein that works as a glue. It helps cells stick together. So the distinction between ductal cancers and lobular cancers is that ductal cancers have E-coherin, so the cells stick together and try to form tubes or ducts. Lobular cancers don't have E-coherin, so the cells tend to spread out because they don't bind together. That's why anatomically they can be a bigger problem. Despite that, though, biologically speaking, lobular cancers tend to be strongly estrogen receptor positive, strongly HER2, strongly progesterone receptor positive. So their biology is actually favorable, although their anatomy can be surgically challenging. So the same treatments that are typically performed to reduce the risk of recurrence of estrogen receptor positive tumors apply to this. Taking anti-estrogen therapy, or tamoxifen or aromatase inhibitor, and weight management so that you're making less natural estrogen, avoiding estrogen supplementation like hormone replacement therapy. Those are the kinds of things. Maintaining kind of an anti-estrogen lifestyle. There are some publications on that. Those are strategies that would benefit a lobular cancer. It would benefit both if they're estrogen receptor positive, but lobulas are almost always strongly estrogen receptor positive, progesterone receptor positive. So they tend to be more responsive to anti-hormone targeted therapies.
What are your thoughts about cryothermal ablation, especially the immune effects that the immune benefits it would offer, immune stimulation, in addition to the #1 objective of being the cryoablation itself?
Right. So I've been very interested in the cryoimmunology of cryoablation, meaning the immune effects of cryoablation. I'm interested because it has been a lingering question that shows some promise, but we haven't quite proven that it happens to a degree that it makes a difference in whether or not cancer recurs. We certainly have seen anecdotal events where someone had cryoablation and then a tumor in another place seemed to regress. But I've also seen a number of situations where they had cryoablation in one part and they had tumors in another part of the breast that progressed, that grew. So it's not clear that for every case where you get cryoablation that you get a beneficial immune response that prevents cancers from progressing. It likely depends upon things that we don't yet well understand. And so I think there's a lot of work that needs to be done to understand, which tumors are more likely to produce an immune effect, whether or not you have to supplement it in a way to amplify the immune effect or do something else to modify it. I think, the studies still need to be done. There are some studies that are ongoing looking at triple negative breast cancer in cryoablation, for example, and HER2 positive breast cancers, because those tend to be more immunogenic cancers. But I think I would not at this point say to a patient if they should choose cryoablation primarily because it has an immune benefit. I can't say that it doesn't, but I can't say that it does. And I can't say that, well, I think that there may be some immune benefit, but I don't know that that's sufficient to make a difference. At this point in time, the treatment is really offered as a substitute for surgery, not as a way of turning on the immune system in a way that is to prevent a cancer. I've seen enough examples to know that that doesn't happen often enough, that we've seen enough examples of recurrences in nodes that weren't treated or in other parts of the breast that weren't addressed, which is why, my bias is to treat everything you can see. And then if there's a role for adjuvant therapy, whether medications or radiotherapy, to rely upon that to control the things you can't see, because in many cases, they will present themselves if they're there. And the time of recurrence usually is in about 2 to 3 years for these things to show up if they've not been treated successfully the first time.
How unusual is it for the final pathology report to show a slow-growing tumor to be almost twice the size of the MRI and the ultrasound done 1 week earlier?
This is someone that's had a lumpectomy that had
I don't know, it's just a question I got.
well, I think, a slow-growing tumor is, lobules tend to be the slow-growing tumors. So if I were used, and I don't know if that was the situation there, but the typical example, that we see all the time is that we have a slow-growing lobular tumor that looks like it's 2 centimeters. And then we do attempt a lumpectomy and find all the margins are positive because it's actually 6 or 8 centimeters. And I have just a case I did so 2 or 3 months ago, where the patient had a 2 centimeter tumor that, looked all the world like a 2 centimeter tumor by mammogram, ultrasound, MRI. During surgery, I realized this tissue is definitely not normal around it. And I took as much as I could reasonably take with a lumpectomy, and still all the margins were positive. And so we went back to do mastectomy. So that's kind of how lobulus can really be a great challenge.
Are HER2 fast-growing tumors?
Generally speaking, yes.
So I was really lucky.
Yes, and fortunately, if I don't disclose too much, you're willing to take anti-HER2 therapy. So
Yeah,
what we know is HER2 positive tumors have historically been aggressive tumors that had a high risk of spread, high risk of recurrence, and worse survival. But since discovery of Herceptin and now Perjeta and now some other things, it's gone from being one of the worst behaving cancers in terms of aggressiveness and to one of the best behaving cancers. So it's really a matter of the therapy. The biology hasn't changed. It's still as bad as it used to be in a sense, but the treatments are so effective against it now that it's really important for patients with HER2 positive tumors to be open to having anti-HER2 therapy because it's been a game changer.
Well, my recommendation is you watch the movie Living Proof. That changed my mind.
Yes.
That made all the
You
difference.
hear it here. Hear here.
Yeah. Yeah, halfway through the movie, I was in tears and I just knew I had to do something. What are your thoughts on using Biosorb, and are there any considerations post-Biosorb implant?
So Biosorb is a device that's placed after lumpectomy as a way to provide cavity support. So when lumpectomy is done, sometimes it can be, take enough tumor, it can cause a depression or some change in the shape or appearance of the breast. So there was this product developed, kind of like a small plastic, although it's not plastic, it's absorbable material that's put into the breast to support the cavity and also help guide radiotherapy. I've used it before, but I really have not been a fan of it. I generally feel that, if I was trained to perform oncoplastic surgery, and it's my primary job, I'm a surgeon, but my training was focused on techniques to remodel the breast interior of the breast internally to compensate for tissue that's removed. Now you can't compensate for a large area that's removed so easily with just shifting things around. Sometimes you have to do like a reduction or a lift in order to compensate for that. But the situations that typically addressed by the Biosorbs are about the size of like a walnut, the larger size. That they kind of propose that as a way to fill in the space after removing a typical lumpectomy of about 3 centimeters. Frankly, if the cavity is that small, there are things you can do internally to compensate for that eliminate the need for that eliminate the risk of depression or collapse of the space. I've also found that sometimes it's caused problems for patients. And so my default is not to use it. I've used it in a few cases over the years, but not with results that I've been pleased with. So I rely upon the surgical remodeling of the tissue, not placement of the Biosorb. The last thing is the Biosorb it's also promoted as a way to help the radiation oncologists target the radiation because it has little metal things inside that they can detect to figure out where the cavity is so they can target the radiation. Since I perform intraoperative therapy for these situations, we give the radiation during surgery. It's done. There's no need for radiation after the fact. So there's no need to leave the little markers to tell the radiation oncologist what to treat. We can give the treatment completely during surgery, close the cavity completely, and then the patient's done with radiation without the need for the biosorb or the markers.
Do you know if anyone used DIM to shrink their tumor before surgery?
I don't know anyone who has used DIM effectively to treat their tumor before. Now, I'm just saying I don't know. Not saying that doesn't exist. No, I do have patients that have been on DM and they've come to me for treatment. I can't exactly know if they responded well. I mean, so I can't answer that question. But for the most part, I've had patients that have gone on DM after surgery or after cryoablation as a substitute for tamoxifen. So most of my experience is for people using it after surgery or after cryoablation. There have been just a few cases that I can recall where it was given before surgery or before cryoablation, but I don't recall it being particularly effective in that situation.
With HER2 NEU quantitative ELSA test, what number would represent metastasis?
I don't know the answer to the question because I don't understand the question.
Okay,
Yes,
all right,
but
go to the next one.
we'll go to the next one.
Do you do cryoablation of fibroedemas? And if so, do you bill insurance for it?
All right, so fibroadenomas are benign tumors of the breast. I do perform cryoablation of fibroadenomas. I don't bill insurance for it. We use the same process.
Okay.
The insurance for fibroations, the insurance for fibroadenomas is even kind of more complicated because it's a benign tumor, the reimbursement is much lower. So it doesn't take into the consideration the resources that are needed for that. Now, that said, fibroadenomas are benign tumors that generally don't need to have anything done with them. So I generally don't do cryoablation of them because I generally tell patients that it's not needed. If they want to have it removed because it's a lump, then cryoablation will give them a bigger lump. So it doesn't make as much sense to remove it to avoid it doesn't make as much sense to cryoablate it to avoid a lump because again, cryoablation will give them a big one. So I think if the lump is a problem, then doing a small incision and taking it out makes a lot more sense to me than cryoablating it. So generally speaking, I don't recommend it, but if that's the only option that the patient's willing to accept, I'm willing to do it.
Would it be worthwhile to get cryo if one has a gene mutation, even if the existing tumor is ablated with cryo? Does the gene mutation increase the risk of other tumors potentially showing up on another part of the breast?
Well, the gene mutation generally does. Now, but that doesn't mean you can't have cryoablation. I mean, we usually advise a patient that you have a higher risk of recurrence just because of the gene mutation, but they could still have cryoablation. They can still have a lumpectomy. They're not required to have a mastectomy. In addition, although the risk of recurrence is high with the gene mutation, the lifetime risk diminishes the older you get. So if you're 20 and you have a BRCA2 mutation, you have an 80% lifetime risk of having breast cancer. But if you're 65 with a BRCA mutation when you're diagnosed, you have a 20% chance in your remaining life of having it. You don't still have an 80% lifetime risk because a lot of your lifetime has already passed. So for an older woman with a BRCA mutation, if she wants to have a non-aggressive treatment, whether lumpectomy or cryoablation, I mean, it can be done. She still has more of a risk of recurrence than another 65-year-old without a mutation, but it's a modestly elevated risk, not a high risk.
My thought is back to, is it worth having a mastectomy because of the BRCA, or should you? Kind of.
Yes,
I mean,
we have 5 minutes left,
Yeah.
so I'll answer that question and any others you may have. But in the remaining 5 minutes, that is a very good question, and so it has to be. The answer is nuanced. So if someone is young and they have, say, a BRCA1 or BRCA2 mutation, which are high risk mutations, then they have an 80%, 60-80% lifetime risk of having a breast cancer, invasive breast cancer. And if a BRCA1, a high risk of having an aggressive breast cancer. So for those patients, it makes sense to recommend preventive surgery, because once they've already, preventive mastectomy only improves survival, only has a survival benefit if you do it before there's a cancer diagnosis. Once there's a cancer diagnosis, then the risk of the cancer recurring is competing against the benefits that you would get from removing the breast. So it doesn't really matter if you remove the whole breast or remove both breasts. The cancer is now going to dictate how long you're going to live. If you want to dictate how long you're going to live with respect to breast cancer, then prophylactic surgery is a way to do that. So for those young women with a lifetime risk that's high, we recommend prophylactic surgery. As one gets much older, in the 60s, as I indicated already, your remaining lifetime risk of that cancer is less. It's 20%. So it's more just above average at that point. So you don't need to have a mastectomy done then, because if you're getting screened, you can diagnose the cancer early and control it more effectively than you can control it if you're young. So it largely depends upon age. There are also mutations that are not high risk, they're intermediate risk. Some have a lifetime risk and they're 30 to 40% lifetime risk. And those don't need to have mastectomy. You need to have more surveillance, but not necessarily a mastectomy.
Last question. Does fibrocystic breast turn into cancer? Mine did. It took 30 years. The lump has been there since 91.
Yes and no. You have to be careful with the question. Fibrocystic change is a natural part of the breast and is common throughout the breast. There are some areas where it might be more prominent, and some people have more of a problem with fibrocystic changes than others, but it's basically just natural background in the breast. Every woman has it to some degree. So the fact that a cancer forms where fibrocystic change is located, it's like fibrocystic change is everywhere. So you can't assume just because you have fibrocystic change and a cancer there that fibrocystic change was the direct cause. That said, fibrocystic change is more common in the upper out of the breast because most breast tissue is there. Breast cancers are more common in the upper out of the breast because most breast tissues are there. So there's a physical association with it that's not necessarily a cause and effect. Lastly, fibrocystic change is a proliferative condition in the breast, means that there's something that's stimulating activity in the breast. So anything that stimulates the activity of benign things can also stimulate the activity of cancerous things. So there is an association with fibrocystic changes in breast cancer, but it's not a causal relationship. It's just a manifestation of the breast being more reactive to estrogen or whatever, and having breast cancer happens in the part where things are happening. Mostly benign things, but breast cancer can happen there as well. So on that question, do you have one final one?
No, I was going to say
Okay.
For all the ladies that were listening, they appreciate your time. We're really happy to hear you and for your time.
Well, I appreciate your time to make this a more interesting interaction than just having me talk to myself or to a screen without an audience.
Anytime, it was fun.
This is certainly a first time for us to do it this way, but I think that it is actually a really good way to communicate and get some of the questions. So we'll do it again sometime.
Okay.
If you come back.
I'm good.
Thank you for joining me.
Thank you for being here.
And
for all the good care you take of all the ladies. I hear so many wonderful things about them.
Well, I'm doing my best.
They all let me know after they've been here.
Thank you so much for your advocacy and making sure that people know that this is an option. It's not necessarily the best option, but for those that are willing to accept other options, this is certainly potentially one. And for those who've never been offered cryoablation as a potential option, it might in fact be a really good option for many. So thanks for helping to make sure the word gets out about it.
I enjoy it.
Thank you.
Makes my day.
Thank you. Well, on that note, we'll wrap up and hope to see you again in the future.